Hello there. Welcome to my education channel, YouTube Surgery and Orthopedic Education. This video is next in my series of YouTube teaching video cast for undergraduate and postgraduate medical students. In this video lecture today, we are going to talk about specific cervical spine injuries. In the end, please subscribe to our channel and give us a like if you find the discussion useful. So, let us go and get started. Cervical spine injuries can occur by three main mechanisms. The first is a direct trauma to the neck itself. The second mechanism is the motion of the head relative to the vertebral column, or a whiplash injury, as often occurs in motor vehicle accidents when the body is restrained with a seat belt. A third mechanism of cervical spine injury is a direct axial or vertical load imparted on the cranium, causing axial compression across the cervical vertebrae, resulting in a burst fracture and a spinal cord injury. A history and examination are important in identifying cervical injury because more than one injury may be evident. Cervical fractures and dislocations can present with neck stiffness, swelling, and pain. The Nexus CS spine, low risk criteria, and the Canadian CS rule may be used to determine indication for cervical spine radiographs. Upper cervical spine injuries refer to traumatic bony and ligamentous injuries involving the occipital condyles, atlas, or C1 or axis or C2 vertebrae. C2 or axis fractures are the most common among upper cervical injuries. These injuries can occur in various settings, including a skivora, that is, a spinal cord injury without radiographic abnormality. Subaxial or lower cervical spinal injuries involving C3 to C7 vertebrae are commoner than the upper cervical injuries. The pattern of the lower cervical spine injury depends on the mechanism of trauma, such as hyperflexion causing teardrop fractures, hyperextension causing compression fractures, axial compression causing burst fractures, and distraction flexion resulting in facet subluxation or dislocation injuries. The imaging modality of choice for the diagnosis of cervical fractures and dislocations is the helical CT scan. Following facts should be kept in mind while assessing radiography and CT. The occipital condyle C1 joint should be concentric and should not be more than 2 mm wide laterally. The normal relationship at each facet joint and intact lateral masses. The tip of the dents should be vertical and tangential to Wackenham's line. The normal atlanto-dens interval is less than 3 mm. It is abnormal if more than 5 mm. The soft tissue width at the mid C3 body level is normally less than 5 mm. Normal shape and bony integrity of the dens. Congruent anterior vertebral body alignment. Congruent posterior vertebral body alignment. Congruent spinolaminar line. And excess angulation or widening of each intervertebral disc space. The majority of upper cervical spine injuries are treated non-operatively. Treatment of lower cervical spine injuries can be either non-operative or surgical stabilization depending on fracture pattern, mechanical stability, and the presence of neurological deficits. Typical injuries associated with upper cervical spine injuries are occipital condyle fractures, occipitoatlantal dislocation, odontoid process fracture of axis, atlas fracture or Jefferson fracture, Hangman's fracture of axis, Atlantoaxial instability, and rupture of transverse ligament of atlas. Occipital condyle fractures are uncommon injuries, usually resulting from high-energy blunt trauma. Occipital condyle fractures are fractures that involve articulation between the base of the skull and the cervical spine. The mechanisms of injury usually are axial loading and lateral bending. They are found in association with traumatic brain injuries in more than 50% of cases, and also frequently there are additional cervical fractures. The dysfunction of cranial nerves 6, 9, 10, 11 and 12 is uncommon in acute cases but has been reported when fractures of the occipital condyle remain untreated. Occipital condyle fracture can be a diagnostic challenge because plain radiographs often fail to diagnose this injury. Diagnosis is best made with a helical CT scan. An MRI and or flexion extension radiographs are useful for evaluating any associated occipitocervical instability. Most fractures are best treated with immobilization with a rigid cervical collar for 6 to 8 weeks. Occipitocervical fusion is indicated in the rare cases where occipitocervical instability is present. The Occipitoatlantal Dislocation or Occipitocervical Dislocation is a severe ligamentous injury to the upper cervical spine in which the vertebral column separates from the skull base. The most common mechanism of this injury is a high-speed road traffic accident. The dislocation may be anterior, posterior, or vertical. It is also known as orthopedic decapitation because in it the spinal column separates from the skull base. This is a rare injury usually caused by high-energy trauma and is fatal in 70% of cases. The standard of care for the evaluation of the occipitoatlantal dislocation is having a multi-detector CT scan. The Powers ratio is used to assess an occipitoatlantal dislocation on plain radiographs or CT images. The Powers ratio is the ratio of the distance between basion and midpoint of the posterior arch of atlas to the distance between opistheon and midpoint of anterior arch of the atlas, or it is BC by OA. Opistheon is the midpoint of the posterior margin of the foramen magnum and the basion is the middle point of the anterior margin of the foramen magnum. A Powers ratio of 1 or more indicates anterior translation, whereas 0.75 or less indicates posterior translation. The treatment is provisional stabilization with a halo brace followed by occipitocervical fusion or fission. A skull traction should be avoided in most cases. The fractures of axis or C2 vertebra involve either the odontoid process or the isthmus. The latter is known as Hangman fracture. The fracture through the odontoid process or dens or peg of axis usually results from a flexion injury. Anderson and D'Alonso classification classified these fractures as type 1, type 2 and type 3. Type 1 is a fracture of the tip or the upper part of the odontoid process. Type 2 is a fracture at the base of the odontoid process. Type 2 is the commonest type, but it is usually unstable and has a high risk of non-union. Type 3 fracture of dens passes through the body of the C2 vertebra. Type 3 fracture has the best prognosis for healing after non-operative treatment. In odontoid fractures, a neurological injury is rare. Treatment of odontoid fractures is usually conservative or non-operative. Type 1 and Type 3 odontoid fractures usually heal with external immobilization in a hard collar or halo jacket in 3 months. Widely displaced and unstable Type 2 fractures are treated with an anterior compression screw and non-unions require a posterior C1-C2 fusion. The burst fracture of the ring of atlas or C1 vertebra is called Jefferson's fracture. It usually occurs due to a high energy trauma due to axial loading of the cervical spine in young patients or low energy falls in elderly. The occipital condyles crush the lateral masses of the C1 vertebra. A typical mechanism of injury is diving head down into a shallow water. In 50% of the cases, there is an associated spine injury, and in 35% there is an axis fracture also. An intact transverse ligament is the most important factor that stabilizes C1 with respect to C2. Due to the large space around the spinal cord at this level, the C1 injuries usually present with neck pain without neurological deficits. An open mouth view of C1-C2 demonstrates C1 lateral mass deviation, but the diagnosis is often missed on plain radiographs, so a CT scan is required to make the diagnosis. The rule of Spence is used to evaluate the likelihood of injury to the transverse ligament of atlas on an open mouth epiradiograph. Rupture of the transverse ligament is present if the combined lateral mass deviation is more than 6.9 mm. The treatment is non-operative with a rigid cervical collar or a hollow brace. Hangman's fracture is a traumatic spondylolisthesis of axis or C2 vertebra on C3. The mechanisms of injury are hyperextension, axial loading, flexion distraction, and flexion compression. It is a bilateral fracture through the pars interreticularis or isthmic portion of the axis vertebra with a subluxation of C2 on C3. The name Hangman's fracture is a misnomer because it is mostly caused by high-velocity vehicular injuries and only rarely by hanging. If Hendy classified the injury into three types, the treatment is non-operative with a rigid cervical collar or a hollow brace. Atlantoaxial instability is an abnormal movement between the first two cervical vertebrae, that is, between the atlas and the axis. The condition is usually congenital, but in adults and elderly it may occur due to an acute trauma or a degenerative disease respectively. A symptomatic radiographic atlantoaxial instability is seen in up to 30% of patients with Down syndrome. The injury usually recovers either spontaneously or with traction followed by a cervical collar. The cases due to isolated traumatic transverse ligament rupture leading to C1-C2 instability are treated with posterior C1-C2 fusion using C2 pedicle screws passed through the C1 lateral mass. The transverse ligament of atlas is a primary stabilizer of the upper cervical spine. This usually ruptures from a force applied to the back of the head, like after a fall on the back. The injury can occur in isolation or with an atlantoaxial subluxation or as an avulsion fracture of the tubercle on the lateral mass of the atlas. A helical CT or MRI is the best modality to detect this injury. The Dickman's classification divides this injury in two types. Type 1 injury is an isolated rupture of the transverse ligament of atlas without a bony fracture. It is treated operatively with posterior C1-C2 fusion. An alternative fixation method is the galley wiring. Type 2 injury is an avulsion fracture of the tubercle insertion of the ligament. This injury is treated non-operatively with immobilization.